Okay, let's unpack this. We're tackling one of the densest, most difficult, and frankly, most painful topics in recent history, conversion therapy.
Yeah, absolutely. We're looking at what the professionals call sexual orientation change efforts, or SOCEs.
Right. And the sources you've shared with us, they take this really complex, layered look at the intersection of religion, academia, psychology,
And most importantly, just serious personal trauma.
with a very specific focus on documented practices at Brigham Young University, BYU, during, the pivotal 1970s.
That's it, exactly. Our deep dive today is essentially a historical investigation. And when we use the term conversion therapy, we're defining it pretty broadly.
Any treatment aimed at changing someone's orientation or identity.
Precisely. And our mission here is, I think, very clear. We need to trace the professional and institutional timeline of these practices
In contrast, the documented, the clinical research protocols,
with the harrowing and often contradictory emotional accounts of the survivors.
and then map out how these major medical and religious organizations just completely changed their positions over the last half century.
It's a study in institutional lag, really.
It is how rapidly the medical consensus can change and how slowly certain institutions, bound by faith and policy, can struggle to keep up.
Yeah, to understand how these attempts at change really took root, especially at institutions with such strong religious ties, we have to go back. We have to establish the environment of the mid-20th century.
The psychological view is just fundamentally different.
Totally.
Yeah.
In 1952, the American Psychiatric Association, the APA, published the DSM-I,
Mhm.
and right there in that first official diagnostic manual,
Homosexuality was explicitly classified as a sexual deviance, a pathology.
a pathology. So if it's a pathology, it's something you have to fix.
And the reigning philosophy and treatment at the time was behaviorism, which brought us aversion therapy.
Precisely. Aversion therapy was the leading conditioning technique. It was designed to associate a person's unwanted attractions or behaviors with highly negative stimuli.
Like pain or nausea.
Exactly. The premise clinically was pretty straightforward. If you could condition out alcoholism or certain compulsions, maybe you could condition out same-sex attraction.
And it is so crucial to state, this was not some fringe operation happening just in Utah.
Oh, not at all. The sources show that major prestigious institutions, we're talking Harvard Medical School, the University of Pittsburgh, the University of Wisconsin, they were all conducting this kind of research.
Often using electroshock methods.
Yep. This followed early reports of success treating other things, like alcoholism back in the 1940s. It was considered, cutting edge, if painful, science.
And I imagine those early outcome statistics, even if they were limited, must have provided massive institutional cover for what came next. What did those studies actually claim?
They claimed some pretty significant changes, which really fueled the hope that change was possible. For example, a 1957 British study reported 15% of a cohort showed a measurable shift toward heterosexual preference.
Okay, so not huge, but something.
Right, but then a 1958 British study was even more dramatic. It reported that 65% of people who finished the full course of treatment had shifted, citing an increase in heterosexual interest.
Wow. Numbers like that would give medical and religious leaders a lot of hope that this malady, as they called it, was treatable.
For sure. But even as these positive statistics were being published and driving this momentum, the very foundation of the pathology model was, well, it was collapsing.
That's the real irony of the timeline, isn't it?
It is. The real scientific tide began to turn with Evelyn Hooker. Her 1956 research, it was seminal. She used Rorschach tests to compare gay and straight men.
And what did she find?
Her conclusion was tentative, but just devastating to the existing model. She suggested that homosexuality as a clinical entity, as in an inherent psychological problem, it simply didn't exist. She found no difference in psychological adjustment between the two groups.
That research must have opened the floodgates. How quickly did the APA change its position after decades of calling it a disorder?
The change was rapid and seismic. After huge professional debate and all this mounting evidence, the APA voted to declassify homosexuality as a mental disorder in the DSM-2. That was 1974.
And the American Psychological Association followed suit.
Just a year later, they passed a resolution supporting the declassification and even went further, urging civil rights legislation for gay citizens.
A huge, almost overnight shift in medical understanding.
It was, but there's
Yeah.
a vital footnote here that brings us directly to BYU.
Okay.
The diagnosis of ego-dystonic homosexuality, which is just the clinical term for when someone finds their own sexual attraction unwanted or undesirable, that remained a formal disorder in the DSM-3 all the way until 1987.
So that distinction, The individual's desire for change. That's the critical pivot point for these efforts in religious communities.
Exactly. That's what allowed institutions like BYU to keep embracing these practices, even as the broader medical world was rejecting them.
Mm.
And the environment there was already highly restrictive.
It was, and the policy started very early.
Right. BYU President Ernest Wilkinson set the standard back in 1959. He decided to suspend any unrepentant homosexual students.
And by 1965, that policy was even more solid.
It was. The university would not admit any student with this tendency who hadn't completely abandoned it. The threat of expulsion was just. It was constant,
Right.
foundational to the culture.
And the surrounding religious context wasn't just allowing this search for a cure. It sounds like it was actively driving it.
Oh, absolutely. The theological motivation was a powerful engine. In 1964, church apostle Spencer W. Kimball gave a huge talk condemning homosexual behavior as a malady that could be cured through self-mastery.
And he specifically cited scientific reports.
He did, and that was followed by an internal 1973 church document that stated explicitly homosexuality can be cured as long as the effort was pursued vigorously.
So you have this belief in treatability and the institutional requirement for change. And that's where the Honor Code Office steps in.
Exactly. It was called the University Standards Office then. Gerald Dye, who directed that office during Dallin H. Oak's presidency from 71 to 80, he confirmed the protocol.
What was it?
He said for less serious offenses, the set process for homosexual students was mandatory therapy. And that sometimes included electroshock and vomiting aversion therapies.
Mandatory. So for students facing exposure or expulsion, therapy was the only way to stay.
The stakes could not have been higher. It was the only way to remain in their community and at the university.
This brings us to that critical historical contradiction you mentioned earlier.
It's the central tension in this whole institutional history. Years after his tenure, BYU President Dallin H. Oakes categorically denied that electroshock therapies happened during his presidency. He said they'd been discontinued earlier.
But the record shows otherwise.
The official record absolutely contradicts that memory. BYU accepted Max Ford McBride's dissertation, which documented electroshock research in the psychology department in 1976.
Right in the middle of Oak's time as president. The fact that a sitting president denied a practice that was documented in an accepted dissertation it highlights a massive institutional blind spot. Or, an attempt at historical denial.
It raises profound questions about institutional record-keeping and memory around these very sensitive and potentially damaging practices.
Let's look at that McBride study itself, because that's the detailed clinical record we have of what was happening at BYU in the mid-70s. What did the protocol actually entail?
The 1976 dissertation documented research with 14 male volunteers. And it's important to note, they were volunteers who said they wanted to reduce their unwanted homosexual desires.
Okay, so what was the procedure?
Subjects were shown male and female images, including pornography, and asked to fantasize. Then electric shocks ranging from a minimal 0.1 milliamps up to 20 were applied to the biceps or the lower leg.
And who set the level of the shock?
The subject did. It was said to be barely tolerable. The treatment also used a phallometric device to objectively measure arousal, which patients were told to apply in private.
So the documented official science used minimal shocks, applied to the limbs, meant to be uncomfortable but not crippling. That's the controlled academic record.
That is the official clinical protocol. And in defense of that record, a volunteer organization that provides information about the church, they push back on the most severe claims.
What do they say?
They state that claims of coercion or cruel treatment, like genital shocks, are unsubstantiated and extremely unlikely because the documented therapy used minimal shocks to the arm or leg and was considered mainstream at the time.
The sources also contain these severe personal accounts from former students that just directly clash with this sanitized official record.
They do.
I mean, the sheer difference between a tiny shock to the bicep and these accounts of forced physical violation is it's profound. What does that gap tell us?
It tells us the reality on the ground was far messier and much more traumatic than the research papers would suggest. We have accounts from former students describing being effectively blackmailed into it by BYU security.
They were offered therapy as the only alternative to being expelled and outed to their families.
Yes, a fate that meant losing both their education and their entire religious community.
And the accounts of the treatments themselves? They're far more extreme than what McBride documented.
Dramatically so. I mean, we have one particularly disturbing account, it's uncorroborated, but it's out there, of a former student recalling being forced to take emetics to induce violent vomiting,
Oh, wow.
being stripped naked, watching pornography, and having electrodes placed on his wrists, chest, and his genitals.
That is a level of severe physical and psychological violation that goes so far beyond the documented research.
It suggests an element of abuse that either happened outside official channels or was just never honestly recorded.
And you also see this religious overlay being used to rationalize the severity of the treatments, especially in private practice at the time.
Absolutely. The work of Robert Card, a Latter-day Saint psychologist in private practice, is an example. He used electroshock and hypnotherapy. He tried to make a client associate the male physique with bad smells.
And he framed it as a spiritual problem.
He did. The pathology wasn't just a disorder, it was a spiritual invasion. One client remembered Card trying to slice away portions of my personality that were homosexual, attributing the condition to inviting Satan into my life.
That framing just fundamentally shifts the stakes for the patient. You're not just seeking treatment, you're seeking spiritual salvation. And in terms of clinical outcomes, did any of this horrific effort actually work?
The consensus from many survivors suggests no, it was a failure. One person involved in the therapy said plainly that they never changed anyone from gay to straight.
But what did happen?
Some participants reportedly became asexual, which speaks to profound emotional damage, not a successful conversion.
That takes us directly into part 4 then, the modern disavowal. The overwhelming consensus today is that these efforts cause serious harm regardless of whether they work.
The contemporary medical view is definitive. These efforts are ineffective and cause serious harm, what we call iatrogenic effects, including increased rates of depression, anxiety, and, most tragically, suicide.
And the statistics are just staggering.
They are. LGBTQ youths exposed to SOCE showed 2.23 times greater odds of having attempted suicide in the past year compared to those with no exposure.
That rate of attempted suicide is chilling. It really provides the central motivation for the dramatic institutional shifts we've seen.
It provides the ethical imperative. Now, while that consensus is dominant, we do have to acknowledge the complexity in some of the outcome data.
Okay.
For instance, some recent research has suggested that if you correct for pre-existing suicidality in the subjects, exposure to SOCE was actually negatively associated with suicidality.
So the academic debate around the long-term effects is still complex.
It is. And other researchers have found a significant percentage of sexual minorities report shifts in their orientation over time, which just speaks to the general concept of sexual fluidity as a natural part of human experience.
Right. But regardless of those academic complexities, the institutions that once promoted these therapies have overwhelmingly backed away.
The reversals have been dramatic and total. The American Medical Association formally opposed reparative therapy way back in 2000.
And the Robert Spitzer example is maybe the most telling.
It really is. He was the psychiatrist who was so instrumental in removing homosexuality from the DSM in '73. But in 2012, he retracted his own highly influential 2001 study that had supported SOCE efficacy.
Admitting his subjects might have been deceiving themselves.
And that the methodology was flawed.
Yes. We also saw the organizations built around these therapies just fall apart publicly.
We did. High-profile ex-gay ministries were forced to reckon with the documented harm. Exodus International, maybe the largest, closed and publicly apologized in 2013.
And Jonah was shut down by the courts.
In 2015, they were successfully sued for consumer fraud and ordered to cease operations. The tide had truly turned.
So given its deep historical involvement, what is the current official position of the Church of Jesus Christ of Latter-day Saints on conversion therapy?
The modern position is one of, well, significant evolution and careful delineation. By 2016, the Church publicly denounced abusive practices against LGBTQ+ individuals.
And in 2019, they made it very clear.
A very clear official statement.
Yeah.
The Church opposes conversion therapy, and our therapists do not practice it.
That sounds like a definitive end to the practice.
It is an end to the abusive, formalized practice. However, their position still maintains a theological nuance. They acknowledge that shifts in sexuality can occur for some people.
And they continue to communicate to members that change is possible through faith, prayer, and righteousness.
Right, focused on adherence to behavioral standards. But,
yeah.
And this is key, they explicitly state that professional treatment should not assume change must occur.
So it's a transition from mandating a cure to simply allowing for the possibility of personal change within the context of faith.
Exactly.
That is just a fascinating trajectory. tracing the path from that 1952 medical classification of pathology
Mm.
through the coercive practices of the 70s, all the way to this modern, nuanced religious doctrine.
Mm.
We've seen the powerful, documented, and often devastating lived experiences of LGBTQ plus students collide directly with this institutional and scientific desire for a quick fix.
And that collision highlights the fundamental conflict at the heart of this entire deep dive. The tension between institutional requirements, which are often rooted in deep faith, and the reality of personal sexual identity.
It helps explain why students who often felt genuine, unwanted attraction sought these change efforts out in the first place.
It does. And this history underscores the absolute necessity of critically examining historical institutional power structures, especially when the records diverge so sharply from the accounts of those who lived through it.
Absolutely. We've explored the full, difficult spectrum of what's been labeled conversion therapy, from group prayer all the way to physical electroshock. And the conversation continues today around the idea of sexual fluidity itself.
As modern society moves rapidly toward banning the harmful practices of SOCEs, here's a final provocative thought for you to consider. We've seen that the term conversion therapy can range so widely. If legislation successfully bans the abusive clinical and physical practices, what fundamental conceptual shift needs to happen next beyond legislation to fully resolve the deep-seated conflict between religious doctrine and personal identity that drives individuals to seek such fundamental internal change?